Health assessment of older adults. Health assessment of older adults can be done through simple screenings to complex, in-depth evaluations. Health screenings will be done to identify individuals that are in need of further, more in-depth assessment. It can include high blood pressure or cholesterol levels, cancer screenings, osteoporosis screenings, hearing screenings, eye exams, disease screens, foot problems, problems with activities of daily living, depression, and suicide risk. Medicare coverage is more focused on prevention care, although there is still concern regarding inadequate health coverage and low socioeconomic status involved in obtaining appropriate care. In-depth health assessments are time-consuming, and collection of all the important health-related data, this can be done in clinics or in institutional settings. This information will be used to identify patient problems and plan care. It includes objective and subjective data. Objective data, once again, is information that can be gathered using the senses of vision, hearing, touch, and smell. It's collected by means of direct observation, physical examination, and lab or diagnostic tests, while subjective data is information that's gathered from the older person's point of view and is best described in the individual's own words. So when interviewing the older adult, we need to prepare the physical setting. Make sure there's minimal distractions, diffuse lighting, comfortable furniture, privacy, lack of interruption, it's comfortably warm and free from drafts, and assist the resident to the bathroom or mention that a bathroom is available nearby if necessary. Establish rapport. Greet the older person and introduce yourself. Use appropriate use of names. This will indicate respect and it also helps build rapport. Explain the purpose of the interview. Focus on and speak directly to the older person and help that older adult maintain the modesty standards that's set by their culture. Determine the older adult's biggest concerns and focus on those first. Structuring the interview means that we need to plan sufficient time for the interview. Try not to accomplish too much during a single interview. Use a variety of communication techniques to ensure that the client understands the information. Avoid medical jargon. They may not understand our language. Speak slowly and clearly. Use simple messages, but don't be patronizing. Remain attentive and calm. Allow clients to complete their own sentences and don't interrupt. And don't end an interview too abruptly. And set up a time for further interaction as necessary. Health history should be obtained prior to the physical assessment. We identify basic data, which includes a history of health concerns and current health issues. Much is going to depend on the cognitive level of the individual and the complexity of his or her particular medical history. If the client is unable to provide an answer, move on. And you may need to ask questions of a family member to fill in details. History is going to help determine areas that need addressing or further exploration. Objective information is obtained during the physical assessment. It can verify subjective data obtained during the interview and observe mood and behavior in addition to physical observations. Realize that older adults have different physiological responses than younger adults, such as a very small change in temperature can indicate infection. Select a location that promotes physical comfort and maintain privacy. Make sure that you gather all the necessary equipment before you start the assessment. Head-to-toe approach will help to assess systematically, and it's most commonly used. Techniques will include that inspection, palpation, auscultation, and percussion. Inspection is the most common method, and it uses our vision, smell, and hearing to collect data. The nurse has to be active, alert, and aware, and begin when the nurse first sees the client. It's used to assess the overall level of function and to detect specific areas of need within any particular area of function. Palpation uses the sense of touch in the fingers and the hands to obtain data. It's used for evaluation in many parts of a physical assessment. It will include pulses, temperature, the texture of the skin, and texture and condition of the hair, presence and consistency of tumors or masses under the skin, distension of the urinary bladder, and presence of pain or tenderness. Always palpate the painful areas last. Auscultation will use the sense of hearing to detect sounds produced within the body. Heart, lung, and bowel sounds are typically assessed during auscultation and involves the use of a stethoscope or another sound amplifier, such as a Doppler, to make those sounds louder and more easily heard. Sounds are described according to their quality, pitch, intensity, and duration. And percussion. Again, this is something LPNs do not do, but it's a technique in which the size, position, and density of structures under the skin are assessed by tapping the area and listening to the resonance of the sound. Depending on the amount of vibration or sound that's heard, the presence of masses, fluid, or air can be determined. This does require special skill and training. So the nurse should end a patient interview when the patient becomes, the correct answer is D, fatigued. So vital signs. First of all, we start with general inspection. Determine if any observations might affect the procedure or accuracy of the readings. We need to obtain baseline vital signs during the initial contact. With the temperature, older adults usually have a lower core body temperature. The oral route is going to be most common, but it may not be acceptable for those that have poor mouth control or are unable to follow directions. The rectal route is going to be used with caution, and we don't really use this very often for the simple fact that it can possibly tear those rectal tissues. We do avoid the rectal route if there's rectal bleeding, if the client has had an MI, or in events of rectal surgery. Usually it's going to be slightly higher, about 1 degree. Axillary is often inaccurate because of the loss of tissue in the older adult. The tympanic method is quick and non-invasive, but unfortunately it's often inaccurate. With the pulse, position should be consistent with each time the pulse is checked. In other words, are they lying, sitting, or standing? And the radial pulse is going to be the most common one that we use. It can be assessed at various sites on the body, including the temporal, carotid, brachial, femoral, popliteal, posterior, tibial, and dorsalis pedis, as well as at the apex of the heart. We need to assess and compare pulses bilaterally. The normal pulse rate in adults is going to be from 60 to 100 beats per minute, but readings outside this range or significant changes will call for further assessment. Irregularities are going to be common, but again, might require further assessment. Compare those irregularities to the apical heart rate to determine perfusion. And remember, count for a full minute with any irregularities. When you're accessing the apical heart rate, provide for privacy and modesty. With respirations, place the older adult in a comfortable position to maximize ease of breathing. Assess the rate, depth, and ease of breathing. A range of 12 to 20 breaths per minute is considered normal, but it might be slightly higher in the older adult. Slightly irregular breathing rhythms are not unusual in the aging population, but abnormal findings do require further assessment. A decrease in the resting respiratory rate of the older person might indicate impending infection, and it may appear before an elevation in the temperature. And chest expansion is often decreased because of alterations in the shape of the thoracic cavity, muscle weakness, sedentary lifestyle, or disease process. And with blood pressure, position the older adult so that the upper arm is at the level of the heart. Cuff selection is going to be very important and should be based on the client's upper arm size. A cuff that's too wide will produce an inaccurately low reading. And readings are going to vary widely. Reduce those false readings by being careful of the position, stress, pain, exertion, eating, or smoking right before the reading. And aging individuals are going to be susceptible to posture-related changes in blood pressure. Simple assessments of vision and hearing ability would be based on empiric data, the way the individual responds to visual or auditory clues. Observe whether the person is able to read or do close work that requires good central vision, or whether he or she watches television or other sight-related activities. And talking with older adults can reveal difficulties with hearing. A psychosocial assessment of the older adult is going to be performed to determine whether that older person is alert and aware of their surroundings, suffers from confusion or delirium, or dementia, and can be performed by direct observation or a tool such as the mini-cog, which is highly regarded and is a quick, effective way to identify cognitive impairments. With social function, observe the amount, frequency, and type of social interaction. The minimum data set 3.0 was designed to help improve the quality of care in extended care facilities, and it helps improve and standardize assessment procedures. It reviews long-term care residents' ability to perform activities of daily living. The goal is to increase reliability, enhance accuracy, expand usefulness, and help improve clinical assessment. It should also help caregivers identify problems and develop interventions while monitoring outcomes. And it should be completed on admission, significant status changes, and annually. The MDS 3.0 should improve client input into the process. It is something that is required by Medicare, and it evaluates a facility's performance. Health status changes in older adults are going to be subtle and not the same as we have learned to expect in younger adults. Early recognition and treatment of change in status can prevent serious harm for the older adult. Different tools have been developed to help with a systematic and comprehensive assessment. The Fulmer Spices talks about sleep disorders, problems with eating or feeding, incontinence, confusion, evidence of falls, skin breakdown, while FANCAPES involves fluid, aeration or oxygenation, nutrition, cognition and communication, activities or abilities, pain, elimination, and skin, along with socialization. So SPICES is an acronym for what types of conditions? This is going to be B, marker conditions that may indicate increased risk for functional decline.